This week, we're going to be talking about neonatal hypothermia. This is one of the most easily preventable but yet commonly sick condition in the neonates, and is actually associated with a high morbidity and mortality. So neonates can actually die from hypothermia or have neurological consequences, especially premature babies. I'm sure sisters in our unit have had a screaming when we receive a neonate with hypothermia. So I hope this video is going to make them understand why we tend to act the way that we do, and it's also going to help the young doctors and district hospital doctors know how to prevent hypothermia in neonates so as to prevent mortality and morbidity. Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. So neonatal hypothermia is actually a global problem, even though it is most prevalent in developing countries like South Africa. It is defined as an axillary temperature of less than 36.5, and it is categorized into mild, moderate, and severe. Mild hypothermia is when the temperature is between 36 to 36.4 degrees Celsius, and moderate hypothermia is when the temperature is between 32 to 35.9 degrees Celsius, and severe hypothermia is when the temperature is less than 32 degrees Celsius. And this is the one that is actually associated with increased mortality and morbidity. So we need to make sure that they never get to reach those temperatures of 32. Otherwise, chances of that neonate dying or having neurological consequences become very high. Okay, so the next step in understanding neonatal hypothermia is to ask yourselves these two questions. Why do neonates, why are they at risk of having neonatal hypothermia, and how exactly do they lose the heat? So let's start with the why. Why are they prone to hypothermia? The risk factors for hypothermia in neonates: one is the larger surface area that they have in relation to their body weight. Secondly, they have decreased subcutaneous fat. So the subcutaneous fat is actually needed to insulate them, especially premature babies or growth restricted babies that are lacking the subcutaneous fat. They are more at risk of hypothermia. Thirdly, they have immature skin. So meaning that the more premature you are, the more at risk of hypothermia you're going to be, because of also the immature skin that you are having. So skin is actually needed to protect the child from hypothermia. Fourthly, they have high body water content as opposed to bigger kids. So this makes them at risk of hypothermia. Number 5, they have poorly developed metabolic mechanisms. For example, like shivering. Neonates are unable to shiver, and shivering is actually needed to generate heat in the body. So because they are unable to shiver, it means they will be at risk of having hypothermia. And the last one is the fact that they have altered skin blood flow. So the blood flow in the skin is actually needed to distribute heat throughout the body. So because we've said they have an immature skin, so it means also the blood flow into the skin is also going to be immature, and therefore less distribution of heat throughout the body. So that is the why they are at risk of hypothermia. Those are the risk factors. Now the second question is how. What are the processes that they can lose heat through? So heat balance is actually affected in neonates by humidity, by the airflow, by direct contact with cool surfaces, and by the ambient air temperature. So there's actually 4 processes in which neonates can lose heat. The first process is through radiation. So this is a newborn skin which is exposed to distant cold surfaces. So this is an exposed neonate who is placed next to a cold wall, or next to a cold cupboard, next to a very big cold table. So losing heat through radiation, the neonate doesn't really have to be in contact with that surface, but by the virtue of being close to it, and it's a big surface area and it's cold, they can then lose heat through radiation. The second process is losing heat through evaporation. So this is when the neonate is wet, and this neonate can lose the heat through the surrounding air from the wetness on the surface of the skin into the air. So we say this is losing heat through evaporation. So this is why it is important when newborns are born, they get dried up immediately, because if that doesn't happen, they will lose heat through evaporation. The third process is losing heat through conduction. Now, this is a neonate who has been welcomed into a cold surface. So you are taking a neonate from the uterus, which is a warm environment, and you are putting a neonate in on top of a cold bed. So that is losing heat through conduction. Now the neonate is in contact with the cold surface. So this is why when we are expecting a newborn to be born, we need to preheat our beds so that we welcome that newborn into a warm environment so that they don't lose heat through conduction. And the fourth process is losing heat through convection. Now, this is a neonate whose skin is exposed to surrounding air, for example, or they lose heat through a draft of air that comes into the room, like neonates that are in a room that has windows open or doors open. So the cold air that enters through that window or through that door is going to actually affect the neonates. They can lose heat through that cold air, and we say this is losing heat through convection. So after understanding the risk factors of hypothermia and how neonates lose heat, then it would safely make you understand why we treat them the way we do, why we cover them with the bubble plastics, why we put boots and caps. It has to do with the whys and the Let's look at the pathophysiology of neonatal hypothermia. So when neonates are actually experiencing cold stress, they have to divert calories to produce heat. So that means if they have to divert calories, it means this will then impair their growth. And also, as I've said, that they have diminished metabolic responses. That is, they can't shiver when they're feeling cold to generate heat. So instead, they use non-shivering responses. This is through chemical thermogenesis. This is through activation of the sympathetic nervous system that is found in the brown fat or subcutaneous fat of these neonates. Now, if you're dealing with a preterm baby or a neonate who is growth restricted, who is lacking the brown fat and the subcutaneous fat already, it means even this process will be difficult for this neonate to produce heat through it. Now, after the sympathetic nervous system has been activated in the brown fat or subcutaneous tissue, there will be release of norepinephrine, and this norepinephrine will facilitate lipolysis of fat breakdown, and through that fat breakdown there will be release of fatty acid, and those fatty acids will then get oxidized, or oxygen will be added onto them and forming through a process called oxidation. And it is through this process that heat will be generated and the neonate will try and rewarm her or himself. Now, this process of oxidation, it's actually an energy consuming process, or it utilizes glucose a lot. And it means now, on top of this patient having hypothermia and having to generate heat, this neonate will run a risk of having hypoglycemia, because he or she needs to use a lot of glucose or energy for him to rewarm him or herself. So there will be hypothermia followed then by hypoglycemia. And on top of that, this process also consumes about 2 to 3 times oxygen. So if this is a preterm child who already has respiratory problems that are making him or her hypoxic, it will mean now with hypothermia, this neonate will run a risk of having severe hypoxia because of this. And the severe hypoxia that this neonate will have will then make this neonate to go into an anaerobic respiration with the release of lactate, and that lactate will cause metabolic acidosis. This is where we talk about the triad of hypothermia. So it's actually hypothermia followed by hypoglycemia, then metabolic acidosis. And if we're looking at metabolic acidosis, acidosis have been found to cause pulmonary vasoconstriction. So now if you have a neonate with respiratory problems already, or you have a neonate that you are resuscitating is hypoxic, and on top of that is hypothermic with acidosis, that acidosis will actually cause vasoconstriction of the pulmonary capillaries, and therefore the oxygen that you are giving this neonate will not be able to go to the lungs because the pulmonary vessels have vasoconstricted because of the acidosis that has been caused by the hypothermia. So these are the complications that hypothermia can be associated with. So this is why we do not want our neonates to actually get hypothermic. So I hope this makes sense, and it actually explains why it freaks us out to get a neonate who is hypothermic, because they will get all these complications that I have mentioned. So how are we going to prevent this neonatal hypothermia? So to prevent it, you need to understand the processes, the hows. So the 4 processes that we spoke about. First one was radiation. We said it has to do with the environment, the objects in the environment that are cold. So make sure that the environment that you're receiving your neonates in are always warm. So the room has to be kept with a temperature between 25 to 28 degrees Celsius. I think our delivery temperature in our unit is 26 degrees Celsius, even in our nursery. So the temperature has to be kept between those degrees at all times, not only at delivery. So that is to prevent heat loss through radiation. So evaporation, we said this is a wet baby, so meaning that when the baby has just been born, make sure you dry up that baby so that the baby doesn't lose heat through evaporation, and immediately do skin to skin with mom. And you can wrap the baby with a bubble plastic. If you have a bubble plastic, immediately cuddle the baby and put boots and caps to prevent evaporative losses. And if this is a neonate, most likely who might need to be resuscitated, make sure your radiant warmer has been preheated so that you welcome the neonate into a warm environment, because this neonate is coming from a warm environment in the uterus. So it's important for you to also welcome the neonate in a warm environment. So preheat your radiant warmer and make sure that while you are resuscitating, you're resuscitating into a warm environment, because if you don't do this, this will affect your resuscitation, as hypothermia will worsen hypoxia and your resuscitation will not go anywhere, and your patient will have hypoglycemias and metabolic acidosis. Then the third process, that's conduction. If you welcome the child into a cold surface, because if he gets in contact with that surface, he will lose heat through conduction. And then the 4th process is convection. So losing the heat from the drafts of air that are entering through the doors and windows. So make sure your neonatal unit, the windows are always closed, the doors are always closed, so that there is no draft of air, cold air that is entering in the unit, blowing into your neonate, making him at risk of hypothermia. So that's how we will prevent it. How do we then treat neonatal hypothermia? This will actually depend on the severity of the hypothermia, but the mainstay of treatment for all the degrees is rewarming. There's 2 types of rewarming. You have passive rewarming, you have active rewarming. The milder the hypothermia is, the more passive rewarming you're going to do. Passive rewarming is just to make sure the room is warm, do skin-to-skin contact, make sure your neonate has been cuddled up or wrapped in a bubble plastic, boots and caps are on, and then you monitor your temperature and make sure it's rising up. Then with your starting from moderate to severe, then you would make sure on top of doing passive rewarming, you also have some form of active rewarming. Active rewarming is divided into external active rewarming and internal active rewarming. External active rewarming, you would use it for a patient with moderate hypothermia. So you do the passive measures, and then on top of that, you do external active rewarming. External active rewarming is using things like the radiant warmer. So on top of skin-to-skin contact and making sure that the neonate has been wrapped up, boots and caps, you make sure you're actively providing heat to the neonate by putting him on a preheated radiant warmer. Then with your severe hypothermia. Then on top of the radiant warmer, you might want to do internal active rewarming, which is now maybe starting to using fluids that are warm. You're warming up your IV fluids that you are using, and you might want to use heated humidify air so that the neonate also gets to be warmed internally. And of course, you also make sure that you treat your complications of hypothermia if you've already have some, like the hypoglycemia that we've spoke about, and the patient might actually need to be on CPAP or oxygen if there's respiratory distress or increasing oxygen needs, as we have discussed. So you make sure that you address all those things. So the rate at which your temperature should increase when you are rewarming, there's literature that says when you're rewarming, especially in a patient with moderate to severe hypothermia, you rewarm slowly. Slowly, you increase the temperature by 0.5 to 1 degrees Celsius. And there's literature that says that actually doesn't make any difference whether you rewarm slowly or you rewarm faster. So this is very controversial as to how quickly you want to rewarm your patient. But the important thing is that the patient needs to be rewarmed, passive or actively. The more severely hypothermic you are, the more actively rewarming you're going to need to do, and make sure you treat the complications associated with your hypothermia.